Fantastic. So we're going to be discussing intravenous antiplatelet therapies in acute coronary syndrome. We're going to have future episodes for high-risk PCI or elective PCI, but I thought I would start that with asking you, what are the currently available intravenous antiplatelet therapies in the United States?
Okay, so this probably, Hady, will take us to probably one of the slides that we all looked at when we were studying for USMLE for the early licensing test after med school. We have to understand the way antiplatelets came into fruition or conception for acute coronary syndrome. The only thing that we had available at the time when we started interacting with acute coronary syndrome was aspirin, which is the thrombexane A2 inhibitor or blocker. That is part of the activation and adhesions of the platelets. Then as we start growing more, we have the P2Y12s, we have the oral P2Y12s, and then historically we started with Clopidogrel, ended up with Prasugrel, then Ticagrelor, because P2Y12 receptors are also responsible for activation and adhesion of platelets. Then at the same time, historically, we have 2B3As, glycoprotein 2B3As, which are blockers for the receptors 2B3A, obviously, and those receptors are responsible for aggregation, preventing aggregation of platelets. P2Y12 start getting higher in demand and more efficacious because the idea is very simple. If you have a problem, if you have a plaque rupture, do you want to stop them up from reaching, or you want them to come to the site of the fight and then the brawl, and now you're trying to spread them apart? This is how I look at it. So the idea is you need to stop platelets from even coming to the scene before you start thinking about preventing their aggregation, because you might get overwhelmed if it's a big infarct, if it's a big plaque rupture, big event, and then now you're just trying to prevent platelets from coming in and causing a thrombus. How about you stop them out there? And that was the conception for the only available intravenous P2Y12 inhibitor, which is Cangrelor. That's the only intravenous that we have now in the US, and I could probably comfortably say in the world. And the idea of P2Y12, IV P2Y12 became very important because, again, you want to stop the activation and adhesion early on before all platelets come into the scene, and then you're trying to play catch with it.
Excellent. And why is this still pertinent? You know, we have such strong oral P2Y12, let's say, devil's advocate. We load someone ahead of time in the emergency department. Why is this still important?
So this will take us to a couple of things. To understand the pharmacokinetics of the oral P2Y12, some of them are prodrugs, that's Clopidogrel and Prasugrel, and Ticagrelor is a direct metabolite. You take Ticagrelor, it's in its form to be active inside the body. So in cases when you have someone with acute coronary syndrome, STEMI and STEMI, coming to your lab, that's a major event on the body, physiologically, pathophysiologically, and then that may result in delayed in activation of the drug, converting the drug from prodrug to an active metabolite. And that's why we start having we needed more potent and direct inhibition of the platelets, and that's crowned by Ticagrelor as an oral P2Y12. But even with that, if you look at the pharmacokinetics, each of these drugs that I just mentioned orally, they take between 30 minutes for Ticagrelor, 30 minutes for Prasugrel, about 2 hours for Clopidogrel to reach maximum inhibition effect. And even with the best maximum inhibition effect, it's only 40-60% Clopidogrel, about 80% Prasugrel, platelet inhibition, and then about 88% with Ticagrelor. So even at maximum, which is after a period of time, you are not achieving full inhibition of platelets. The need for IV drug became more important now because guess what? It's on-off. You use IV Cangrelor, P2Y12 intravenously, you know it's going to work within 2 minutes, and the maximum inhibition is 98% of your platelet activity. So truly walking in, by the time your patient is loaded with any of the orals and oral P2Y12, they're on the table, guess what? You might still not have any inhibition. And if I challenge you now to play the devil advocates back to you, when was the last time that your primary PCI took more than 30 minutes, 40 minutes? We have door to balloon times, which is 90 minutes. Most of the time, transradial, and you open the artery, you're done by 15 minutes, by 20 minutes. And I always laugh because if you think about acute coronary syndrome, It's the only type A lesion we're treating nowadays. Like everything else is calcified. And I know on the podcast, when I'm looking at back table list, we have many lectures, atherectomy, plaque modification, because that's the most common cohort of the patient we see. ACS, primary PCI, or STEMI, or unstable angina, they tend to be probably a bit simpler lesions, and you're done with the procedure in 15 minutes. Guess what? Loading in the ER, even before they come to your table, we not got to that time. You are finishing the procedure before you even have a maximum platelet inhibition.
So why not GP2B3A inhibitors, the old timers? What's wrong with them?
Okay, I'm going to be a bit boring and talk about guidelines. So in the guidelines, if you look at the acute coronary syndrome guidelines, the American guidelines, the US guidelines, if you look at that, it's a class 2, it's reasonable, class 2B, reasonable to use 2B3As in cases where you have large thrombus burden, if you have no reflow during your procedure, if you have no reflow or slow flow, then you can probably use it as a bailout strategy, 2B3As. If you look at stable coronary disease, which we're not covering, it's actually class 3. If you have someone comes from home with an abnormal stress test and you find a 90% Prax LAD, it is class 3 to use 2B3As for platelet naive, platelet inhibition naive patients. Because I think if you go back to the mechanism of action, it's about platelet aggregation. If all platelets are in town, you want to disperse them out. It's like the teenagers next door having a party. You don't want to have the party to begin with before you call police and then spread them apart. So 2B3As, you can use them, but the guidelines are the guidelines.
Is it because of the bleeding?
Yeah, and obviously
issues?
I'm going to get there in a second. It is definitely high risk of bleeding. We know this, and this was replicated in multiple trials. There's a beautiful recent review in European Heart Journal, which kind of go over, because we don't have a head-to-head P2Y12 IV Cangrelor versus 2B3A IV antiplatelets. We don't have that trial. But if you look at the most common repetitive finding in most of the studies that we've done or meta-analyses, you always see that the bleeding risk that comes with 2B3As and the prolonged effect. You have to remember that as well. And then we both probably practice at a time when we used to use 2B3As in our practice. You need at least a good 6 hours for the full effect to wash out. When you talk about P2Y12 inhibitors such as Cangrelor, it works in 2 minutes. It washes out by 30 minutes to one hour. You go back to full platelets activity as if nothing had happened.
Absolutely. I mean, just anecdotal experience myself when I noticed when I switched to IV P2Y12 from 2B3A. Of course, there is a small subset of patients who still need 2B3A and a massive clot if you want to inject something inside the clot. But just the spontaneous bleeding, like gum bleeding, for example, you see it all the time in 2B3A. I've never seen it with IV Cangrelor. Radial artery access bleeding, like that's so aggressive. So I'm glad we have a tool and a medication right now to, first of all, on and off, and second, much less aggressive from a bleeding standpoint.